Hello, everybody. It's good to welcome you back on our Second Life BVI webinar. All the BVI team hope you and your family are safe in this difficult situation. We know the COVID-19 situation. So today we hope to offer you the best knowledge of the Finevision lenses solutions. This year, you know, we are celebrating the 10 years anniversary of the Finevision, the first trifocal technology to achieve spectacle independence. During these 10 years, you saw a continuing evolution or changes of the Finevision family to propose you the best solution for your patients, linked with their expectations in a safe, long-term way. So today, I'm glad to welcome Dr. Heng from Manila, Philippines. Dr. Heng has a huge expertise in multifocal lenses. In my opinion, is one of the best teachers I've never heard during international congresses. He's going to review the Finevision family and more deeply the technology behind each trifocal solution, linked with his own clinical follow-up experience. So Dr. Heng, thank you again for your support, and thank you for sharing today your knowledge. This presentation will be around 40 minutes, supported by live poll. Then we will have 20 minutes of a Q&A session. So over to you, Bobby. Thank you.
Hello and good day to all. Please call me Bobby. All my friends call me Bobby, and welcome to the Finevision Trifocal IOL webinar from all parts of the world. So tonight, it's nighttime here in Asia. So we want to discuss the innovations in trifocal IOL technology and explain to you how the Finevision family of lenses evolved. So for my financial disclosures, I do a lot of IOL studies for many companies, including Fision. So we start with a poll. I think Sebastian has some questions to ask of the audience. Sebastian?
Yes. So I'm going to send you. So there are two questions. Let's go. So you can vote now. So which kind of multifocal IOLs is now your first choice? So first question. And do you have any experience with trifocal lenses? So I'm going to let 20 seconds to the audience to vote. Okay, I'm going to share the answers. So Bobby, you can see the answers. So on the first questions, what kind of multifocal you are using now? What is your first choice? 60% is trifocal lenses. The second is 20% of EDOF lenses. Any comments, Bobby, on this order? Okay. Do you have...
I think, yeah, most of us, I think, are familiar that there's such a thing as trifocal lenses. Most patients, most doctors probably have moved on from the bifocal to the trifocal, although some stay with their bifocal because they're happy. But the good thing here is some people are willing to try. So those who have not, they're willing to try, because only by trying will you know if your patient is happy. If you don't try, you won't know. So that's what I suggest, is after the webinar and when the practice restarts after the virus infection, I think those who haven't tried should try trifocal IOL.
Okay. And in the audience, 58% have already an experience with trifocal lenses. And 20% willing to try it. Okay?
Okay, so as you can see here in the slide, there are so many lenses to choose from. In our daily practice, I think, like me, I've tried almost all of these lenses except some that are not yet commercially available. But honestly, it's a bit confusing which one to use. So as you try more and more lenses, I think you will end up with some favorites. So this is your favorite go-to lens on your daily practice. And then just like me, sometimes there will be not enough, the IOL power that you need will not be available, and you have a second line choice. So it's good to try, and then you choose one that you like. I'm not here to tell you which one to choose, but it's good to try all and find out what you like. But here, as you can see, the multifocals have become bifocal and trifocal. And then there's these EDOF lenses that are so many EDOF lenses now coming into the market. So over the past 10 years, as you've heard the introduction from Sebastian, the Finevision trifocal actually came out in 2010. And over the past 10 years, one by one, these other companies came up with their own trifocal EDOF solutions. The EDOF actually came later, but they sort of one by one started. But this, as you can see in this evolution, the Finevision started with the micro F, which is if you look at the lens, it's like the one with the Mickey Mouse configuration. That's the micro F. And it is the first trifocal. I actually started using the trifocals in about 2013 when my friends Eric Mertens and Shiraz Daya told me that you should try these lenses because they're good. No? Their patients are happy. So I started my trifocal experience in about 2012, 2013. But as you can see, the visual company did not stop with one model. The other companies, they have only one model of lens, and that's about it all throughout. While in the Finevision, they came up with several iterations or improvements. So the Pod F, which has become a double C loop or the antennas, and then the Pod FT, which is the toric version of the ones with an antenna. And then in 2018, the HP, we call it HP, but it's a hydrophobic and glistenings free because all the previous generations, micro F, Pod F, and Pod FT were hydrophilic, and HP is hydrophobic. And then the latest Finevision is the Triumph, which has longitudinal chromatic aberration. So all these innovations, I will talk to you as we go along the presentation. So we go back, the first generation of diffractive multifocal IOL. So it started with refractive multifocal and then became diffractive. The diffractive technology, actually, the first bifocals, there were rings, and the rings had one step height, and this provided good near vision and good far vision, but there was no add for intermediate. And the main complaint of many of my patients with the first generation bifocals was the glare, halos, and decreased contrast. So we still persisted in using because patients decreased their dependence on eyeglasses. The second generation added another step height. So the rings became two types. One is a higher step height and one is a lower. The higher one is the near and the lower one is the intermediate. So these are the trifocals, the micro F, and those lenses. The intermediate focal point is 80 centimeters and the near focal point is half of that, 40 cm. So these are the sweet spots for the traditional trifocal. And one thing we noticed, which made me shift from bifocal to trifocal, is patients complained of less patients complained of glare, halos, and all of that. So, you know, when you see the patient the next day, the next week, the next month, it's a big relief that they don't tell you, oh, I see these rings, it's blurry, it's waxy. So they're smiling at you. So it really encourages you to use them more and more. Now, there's so this one, I think the first was Finevision and followed closely by the 80 Visa Tribe, but they're about at the same time they came out and they give far, intermediate, and near. So the next innovation about 3-4 years ago was another company. So actually Alcon made this lens wherein there were 3 step heights. So the 3 step heights, what they did was they said this sort of is a quadrifocal, but what they did was they flattened one of the step heights to make that more for distance. So they ended up with a trifocal, but the trifocal has an intermediate distance of 60 and a near of 40, just like all the other trifocals. So now we have three types. So we have the usual bifocal diffractives, which are the Restore Techniques multifocals, the trifocals, which are now the Finevision, the Lisa, the Rainier, and all that. And then we have this three-step height quadrifocal, which is also a trifocal, which is the Panoptics. So now, how do these lenses compare? No? So we did an IIT or investigator-initiated comparison. I did this with one of our senior residents, Dr. Janice Yu, and we did a study comparing the Micro F, which is the Finevision trifocal, the Lisa Tri, and the Panoptics. You just wanted to know how they match up in terms of visual outcomes. So you can see here the properties of the three trifocals. The near ad, the Finevision is the strongest, followed by the Lisa Tri and the Panoptics, but close, 0.25. The intermediate ad, 1.75 Finevision, 1.6 Lisa, and 2.17 Panoptics because of the shift in near vision to closer. Finevision and Lisa are more or less hydrophilic, where Panoptics is hydrophobic. So without the influence of refractive errors, you can see that more or less the far vision is more or less not significantly different between the three groups. This is whether we tested one eye, and then in terms of near vision, we also see that because the Finevision has a 3.5 diopters of near, it has slightly a little bit of better near vision, but it wasn't statistically significant. So the far vision and near vision at 40 cm, they're more or less very comparable. In terms of intermediate vision, this is where we saw some statistical difference, wherein somehow the Finevision and the Panoptics have better intermediate vision than the Lisa Tri. So these are the comparisons for far monocularly. But when we do binocular testing in the patients, more or less they even out. Most patients perform well. So this is a testament to when both eyes are functioning, they both help each other and they give more or less similar vision, far, intermediate, and near. So we go again to a question from Sebastian.
Yes, Bobby, I'm going to send. So here we have three questions. The first one, what is, according to you, the cutoff astigmatism value with multifocal lenses? Second, what is your main fear when using toric lenses? And the last one, do you use multifocal toric lenses to correct patient astigmatism? We are going to let some time, Bobby, just to receive the answers.
So we want the audience to share with us what is their practice, how do they feel about astigmatism.
It's moving, but we can see the trends. Okay, so you can see the outcomes, Bobby. So first questions, the cutoff astigmatism, it's between 0.5 and 1 diopter, 56%. This is the cutoff, the main cutoff to use toric multifocal lenses. And second question, what is your main fear when using toric lenses? The first fear is post-op rotation of the lens. And the second is the lens placement on the axis. And calculation, both together, calculation and lens placement. And the third, do you use multifocal toric lenses to correct patient astigmatism? 47% say yes. Any comments, Bobby, you would like to share with us regarding the...
I think for my practice, I'm it's very similar that we know from publications. I also did a publication wherein I compared some trifocals to an EDOF lens, and we know that as you increase astigmatism, any pre-existing corneal astigmatism or post-op astigmatism affects visual outcome. So the trend now is being more aware of what the pre-existing astigmatism is and to plan for a toric lens. So I myself have a cutoff of 0.75, meaning if a patient has 0.75 astigmatism or lower, then I might not use, but 1 diopter definitely I will use. And about the post-op lens rotation, that is something that the surgeon usually cannot control. That is a function of the IOL property itself and how it adheres to the capsular bag and how stable it is and all that. So I think this poll is very reflective of our worries when we use lenses, no? Our choice of lenses.
Okay.
Okay. The reason why we talked about that is the Finevision lenses look different from all the other lenses. So these are C-loop lenses, there are plate haptic lenses, and there are the Finevision lenses, which are double C-loop. So this, if you have a C-loop, usually our experience is the lens will rotate clockwise post-op. So the Finevision toric lens is a double C-loop. As you can see, it's antennas, so there is more contact with the equator of the capsule. So it's more stable in terms of after you position, there's more contact to prevent it from moving. Now, the other advantage of this double C-loop is that you know how many of us are frustrated when you're aligning the lens. You have your own surgical technique, but for me, I remove the viscoelastic under the IOL, and then I do the fine adjustment to put my toric marks aligned. But if you have a C-loop and you go beyond that, then you have to rotate the lens 180 degrees to go back. Whereas in the double C-loop and also in the plate haptic, you can move the lens clockwise or counterclockwise for a fine adjustment before you remove your INA probe. So it allows you more flexibility and you won't be frustrated by the spinning motion of the lens. So for me, ease of alignment, this double C-loop has an advantage. So about the toric, you each have your own formulas. We're not going to talk about calculations here, but the lens design is such that it helps in terms of fixation and alignment if you have a double C-loop. The next poll, Sebastian.
Okay. So 3 questions again. So does the raw material have an impact on your choice of lens? What is your preference in raw material? Do you think glistening could have an impact on the patient quality of vision? I'm going to wait 10 seconds. Okay. So you can see the results, Bobby. So the first question, does the raw material have an impact on your choice of lens? Yes, for 80% of the audience. What is your preference is raw material? So hydrophobic, 58%. And do you think glistening could have an impact on the patient quality of vision? say yes, 79%.
So from the poll, I think number one, those of us like who've been practicing for more than 10 years, and you've attended congresses, you've read the journals. Um, all the journals about lens material seem to be saying that hydrophilic is bad and hydrophobic is better. Now, when you read the journals, they are comparing a different brand of hydrophobic and a different brand of hydrophilic. So you don't know if the cause of this PCO or whatever is because of design, because of material, because of haptics, because of square edge. So given that, then we all have our biases of which material, and I guess, as you see in the poll, it's hydrophobic. So uh, we will talk about that later. And then about glistenings, the reason why many people are aware of glistenings is because we see it in the slit lamp. So you see the glistenings in the slit lamp, and if you compared several IOL brands to others, you know that some IOLs have more glistening, some are no glistening. So um, it's doctor's choice now if they feel that this glistening does have an impact or does not have an impact on their patient. But of course, you as a surgeon, you want to put the safest lens in the patient's eye so that you don't have a problem of explanting that lens in the future or causing your patients harm. So that's why I think people are becoming more and more aware of glistenings. Okay? So the Finevision also has some innovations in lens material. Why is that? Because all throughout the first 6-7 years of the existence of the Finevision trifocal, the Pod F and the Micro F, the material has been hydrophilic. I don't mind because I don't have any calcifications. My PCO rate is not 50% in 1 year. It's probably like 5 to 10% in 2 years. So I don't mind. It's a simple YAG and the patients are happy again. But because of market forces, market demand, publications, uh, the company decided, why don't we make a hydrophobic version of the same lens? So if you look at these two lenses, they look exactly the same. The only way you will know that the right one, the HP, which also is glistening free, is hydrophobic versus the hydrophilic is the haptics. You see the ridges. There's lines in the haptics. So when you inject it, you know that you're injecting a glistening free hydrophobic. Whereas on the left, the hydrophilic version has a clean haptics. So in the Finevision family of lenses, there are 5 lenses. On the left, there are 2 hydrophobics, the glistening-free HP and the glistening-free Triumph. And on the right are the hydrophilic. So you see the Mickey Mouse configuration of the Micro F and the antenna version of the Pod F and the Pod FT. So why? Because hydrophilics are softer, but it's been said that the PCO rate is much higher than the hydrophobic. So again, the solution of PCO is YAG capsulotomy. But of course, some people feel that it's a complication. We have to explain to the patient why they need another laser, or patients become very happy and they become unhappy, and then you make them happier again. So it's an extra step. I think most of the lenses will have PCO over time, especially now that we're doing more and more clear lens exchange over 5 years, 10 years of taking care of your lenses. There will be PCO, and you will need to YAG them. No? So what we did was we did the prospective randomized study. So here, the hydrophobic, hydrophilic material, the reason why one has more PCO, the other is probably because of the adhesion force. The lens, the capsule sticks to the lens more in the hydrophobic, while in the hydrophilic, it is said that there's less adhesion force. But one of the other factors of PCO is the square edge design, which most modern lenses have. And now, whether it's hydrophilic, hydrophobic, they have the square edge. That's why both have not very high incidence of PCO and YAG capsulotomy. But to put the matter to rest, what we're doing now is we're doing this prospective comparative study of these two lenses, the hydrophilic and the hydrophobic version. And as you can see, at the 3-month follow-up, the lenses have very comparable visual outcomes. Distance, intermediate, and near, they're about 20/20 to 20/25 in all distances. So there's no statistical difference in the visual outcomes because the optics of the hydrophilic and the hydrophobic are the same. Now, what we want now is this study is the only study which compares two exact designs of IOL. So there's the same square edge, the same size, same haptic, same optic, everything's the same, even the same surgeons. And then now we will see over time if the material is indeed detrimental in terms of PCO rate and YAG. Number one, is there more PCO rate in hydrophilic than hydrophobic? And number two, after you YAG, is the visual outcome restored, or the patients would be equally happy with hydrophilic or hydrophobic? So this is a 3-year follow-up. We're coming to 1-year follow-ups, and we will report the outcomes and we will publish it as we go along. So the other innovation over time of the Finevision is in the lens optics. So as you can see here, from the Finevision HP or glistening free, they developed a Triumph lens. We call it a Triumph lens. And what changed is they changed the geometry of the steps. So what they wanted to do was they wanted to put an EDOF component into the trifocal. So making the intermediate vision stronger. And the second consequence is to compensate for longitudinal chromatic aberration. Now, in terms of defocus curve distribution, so how do you differentiate a trifocal from an EDOF is, in the standard trifocal, the strongest vision is distance, next is near, and then next is intermediate. So the intermediate is the weakest. In the EDOF lenses, whether it's the Triumph or other, the strongest is the distance, followed by intermediate, and the least is near. Or in the EDOFs, there's practically very little near. So the slope is a gradual lowering. So the slope of EDOF is gradually descending, wherein the slope of a multifocal has these peaks and troughs. So this trifocal lens maintains some near to differentiate it from a purely EDOF lens, but it also maintains its trifocality. So far intermediate near, but the strength is different from the standard trifocal. Now, the other good contribution of this lens is in terms of chromatic aberration. So it took me some time to understand chromatic aberration, and the optics engineers of visual were trying to teach me this. So first, when white light goes through a lens material, this light is broken down into its component colors. So red, yellow, green, blue, and all that. So this is called chromatic aberration or dispersion. And then the higher the chromatic aberration, the more it contributes to some waxy or blurry vision. So if you have a lot of chromatic aberration from the lens properties, it causes some waxy images. So in a purely refractive lens, for example, your normal monofocal IOL, when the white light goes through it and you break down the colors, you will see that the most important colors are the red, the green, and the blue. And the green is the one that falls on the focal point or on the retina. So if you have a planar refraction, the green is on the retina. Now, what happens to the red and the blue? The red overshoots or is a little bit causing some hyperopic effect, and the blue is a shorter wavelength, so it falls short of the green and it causes some myopic effect. But if you see these two, the contribution of the myopic effect is a lot more in terms of blurring than the red. So the blue is the one that's causing more of these waxy vision phenomena. So if you leave it as this, then this is what the patient sees. Now, when you have a multifocal diffractive IOL, what happens is the refractive portion or the base lens has a refractive effect, so it has more chromatic aberration because the blue is short from the green. Now, in optics, the diffractive part has a reverse effect on the colors. So the blue is farther than the green. So it has less chromatic aberration. So if the blue is near the green or beyond the green, then it has a beneficial effect on contrast sensitivity. So that's what you look at is the blue short or is the blue long? Now, if the engineers of the lens design this new IOL, they have the ability to manipulate the lens, how it comes together. And in this situation, in the Triumph, what the engineers did was to compensate in terms of manipulating the step height properties so that the red, the green, and the blue would hopefully fall in the same focal point and would compensate for this chromatic aberration correction. So how does this work? So I would like to thank Jerome Liok, who helped me with understanding this and providing some of the slides. So in these slides, you see that the trifocal has a far, an intermediate, and a near, and it's the green light that is the plano part of this. So you look at the trifocal humps in the bottom part, you see that the far vision at 19.25 diopters is your far vision plano, but you have a focal point for intermediate and near. So this is what is visible in terms of the green light. Now, when this is a standard fine vision trifocal. Now, when you incorporate or analyze chromatic aberration, each focal point is broken down into several colors. And as you can see, the far vision has worse chromatic aberration, meaning the blue is short of the green, whereas the intermediate and near, the blue is beyond the green. So in terms of chromatic aberration, the intermediate and near are better than the far. That's why most patients, when they complain in a standard multifocal IOL, is they feel that the waxy vision is the distance vision. So when my patients complain, usually they notice the waxy vision when they look at far vision. So you can leave it like this and just manage your patient by explaining to them that this is a natural phenomenon that it will occur. Now, when lenses are designed, they have a choice. So in the regular fine vision, chromatic aberration compensation, in the far, there's none because it is a refractive base. The intermediate and near, yes. In the symphony, so those of us who used a symphony, they know that one of the features of the symphony is also chromatic compensation. And what happens is you see that the far vision, the first set of humps, the blue comes before the red. So they compensated for the far and the intermediate. So that's why the patients with symphony see very good far intermediate. The weakness of the symphony is patients complain that the near is not enough because as you can see here, there's very minimal light energy for near. Now, in the fine vision, you see that a Triumph lens, the newest lens, you see that the far, intermediate, and near, especially the far, they made the chromatic compensation enough so that all three colors are aligned. So you can overcorrect or you can correct just enough. So the engineers wanted to just correct enough. That's why in these lenses, in terms of contrast vision for far, the Symphony and the Fine Vision Triumph both have better contrast sensitivity for far compared to the other lenses, is because they compensated for some chromatic aberration. So the newest lens, the Triumph, is a combination of several innovative technology. Number one is they incorporated an EDOF defocus or an EDOF optical property so that they made the intermediate stronger than the near. That way, doctors have a choice. You have a choice of choosing a trifocal, purely trifocal, or a hybrid trifocal EDOF. This lens has longitudinal chromatic aberration for better contrast vision, and then it's glistening free and the C-loop design. So we're doing this perspective study, and in terms of vision, as you can see, the far, intermediate, and near vision are good, 20-25 in all distances, but it follows the EDOF defocus, which is far is strongest, next intermediate, and next near. In terms of monocular and binocular defocus curve, you see the curve. So this curve follows far, intermediate, far strongest, next intermediate, next near. Now, one of the most important things to test is contrast sensitivity, because if the longitudinal chromatic aberration is working, it helps bump up the contrast sensitivity. And as you can see, the blue line is the triumph. So you see that it has a little bit of a higher contrast sensitivity. In terms of spectacle independence, it's very good, but remember that if you incorporate more EDOF, you have more distance and intermediate, but you sacrifice a little near. If you want your patient to have better near, or the patient requests for near, then you might want to choose the HP or the standard trifocal. So it depends on what the patient wants. But you see, patient satisfaction is very high. So now there's an evolution of technology. The latest lens is a hybrid EDOF and trifocal, which gives a seamless defocus curve from distance, intermediate, near, with longitudinal chromatic aberration, which gives better contrast. So if you choose IOLs and you want them to have better spectacle independence, you have a choice: a trifocal, which is stronger near, or an EDOF, which is stronger intermediate. So, but both have glistening free material, and these are your current choices now. So if you see the family of lenses over the past 10 years, as the other companies developed their own trifocal, Fischl improved on their trifocal lens design, lens optics, haptics. So they evolved from the original concept of giving the patients as much spectacle freedom. Then they changed the haptics so that we have good rotational stability and ease of positioning. And then they gave you a glistening free hydrophobic so that there's less PCO. And then the last one is putting a kicker on contrast sensitivity by providing chromatic aberration compensation. So we will move on to the next part, which is tips and pearls in optimizing outcomes. And I think Sebastian has a poll.
Yeah, thank you, Bobby. So there is only one question here. What is the most important criteria to consider when offering multifocal IOLs to your patient?
Mm-hmm. For me, okay, you answer this first, and then we'll see the answers of the surgeons.
So just a reminder to the audience, so you can ask also questions. You can send the question you would like to ask to Dr. Bobby Yang directly here with the Zoom. You have an icons that you can write any questions you would like to ask. And you can send already this question now. Okay. So for sure, 58% is spectacle independence. It's the most important criteria. Second, it's high expectation of the patient. Patient can afford the lens. Then we have perfect eye condition. Patient wants perfect near vision. And last one, no dry eyes.
So I think that all of us are aligned that when we talk to the patient, so this question flows from the conversation of the surgeon and the patient. So when we talk to our patients, we talk about cataract surgery, we talk about the lens choices, and of course, the patients will ask, what's the difference between the lenses that you're offering? So for me, the most attractive proposition is less spectacle dependence. I don't promise no glasses, but reduction in the use of glasses. So, and if you want to reduce glasses, then you have to provide near vision, just like in the poll. Because patients, if you do a monofocal, then every time they read, they have to use reading glasses. So it's more or less connected in terms of response. Okay, let's proceed. So, correcting presbyopia IOLs, it's a very tricky and very stressful situation. So, it's very time consuming too. But all of these are outweighed because it's very rewarding for the patient and the surgeon, especially if you see the patient smiling after 1 day, 1 week, 1 month, happy. And then the best reward is referring more patients to you. So, what are the important steps to gain good outcomes? No? And I mean, making sure that almost all the variables are being controlled. So first, you have to have good patient selection. Then we talk about IOL calculation. Then we talk about intra-op and post-op care. So in our clinic, sometimes we do manual writing, but the optometrist will always refract. So you will have refraction information, whether electronic, file, or written, and we usually have an autorefractor. So once the patient comes to me, these are the information in the chart, and then I go into my examination. So you're limited by this and your examination before I order some diagnostics. So the first thing that I think about when I select a patient for IOL implantation is this a toric or a non-toric case? No? So if the autorefractor is already telling me 1 diopter or more, then I'm sure it's toric. But if it's 0.5 or 0.75 or 1, then between 0.5 and 1, I need more than one measurement tool to determine if it's toric or non-toric. The second thing, which you can look at in whatever information you have, and the conversation is first, I do a cutoff. So if the best corrected vision or the potential vision is 20/30 or worse, and it's consistent with a degree in cataract, meaning it's very thick and it's 20/30 or worse, then maybe it's correct. But if it's 20/30 or worse, but the cataract doesn't seem to be that thick, there's no posterior capsule opacification, it's not so you kind of doubt that this is correct. So you have to look for pathologies. Pathologies can be anything from the outside the eye to the inside of the eye. Now, the mindset is where you talk to the patient and set the patient expectations. Because during this conversation, you will already have a clue of the personality of the patient, if this patient will give you problems or not. Because if they're hard to please or they're kind of very pushy, then you kind of want to back off and don't push them too hard, or you answer all their questions first and then see how it comes. So you have to have some sort of a gut feeling that this patient might be a good candidate or this patient might be too demanding after. You don't want to get into trouble because you didn't explain things. And then so I explain things so that they understand that there'll be glare, there'll be halos, the far vision will not be perfect, and they might still need glasses. So these are the things that I think we need to be clear of and then set the proper expectations. And then I also ask them, did they have previous refractive surgery? So there's always this debate of some surgeons feel that even if they had LASIK or PRK before, you can put a multifocal, whereas some people feel that you should not and you should just put a monofocal or an EDOF. So this is each surgeon's experience and gut feel if you want to put multifocal or not. Now, in the left, you see that if you did not check the optic nerve, you will not know that the patient has cupping. In the middle, you see that it looks like a pinhole, but this patient actually still had 20/25 vision. So knowing the vision does not tell you that you should not put a multifocal in this because of contrast issues. And on the right, you see ERM, epiretinal membrane, and also this patient still had 20/25 best corrected vision. So how will you tell if you don't have this instrumentation? So it's actually very important that if you go into a premium IOL practice, you're equipped to go into a premium IOL practice by having some of these equipment in your clinic. So other essential tools. So everything seems normal. No glaucoma, no cataract. You've treated dry eye, not a component. Then what do you need to calculate and order your IOL? Then you need an optical biometer. I think also in this day and age where you want to be precise, I think that it's a must-have to have one of these optical biometers. Almaster, Lensar, there's Pentacam, there's the new Heidelberg Anterion. So these are good optical biometers or tools. Now you also need topographers, and then some of us, we have eye trace, a barometer. Some of us have the Aura, have a Varian, have a Callisto, but these are the important tools that you have to go into premium presbyopic correcting IOL practice. So in this example, you see that on the right, it's 0.63 cylinder. On the left, it's 0.84. So if I see this, then you're in the middle of 0.5 diopter and 1 diopter of astigmatism. So it's kind of now each person's gut feel if you want to switch this to a toric or not. But for me, the 0.84 is definitely a toric, and the 0.63 maybe or maybe not. The other factor here is you see the axis in the left, the minus is at 105, which is more or less against the rule. And on the right, it's oblique. So if it's against the rule or oblique, I probably would go with the toric IOL here. If it's a with the rule astigmatism, then maybe I can go 0.75 or less than 1 diopter. But against the rule, I'd probably go for a toric multifocal here. So you see that on the right, it's obviously more irregular than on the left. But the left, there's some irregularity also. If you don't have a topography, you won't know because you're depending on just the IOL master K reading or your keratometers, and you won't know if there's some irregular astigmatism. If you have other tools, you can see if the astigmatism is flat, steep, which axis, this against the rule. You see that there's a superior aberration or a coma, superior coma, and you won't know that, no? If you don't have these tools. So the other thing is some patients will not volunteer that they had Lasik before. And the only way to know is to have a topography. So I think, again, as the population ages and the Lasik population becomes your cataract population, you need to have some sort of a topography in your clinic, whichever brand, so that you can check. So I think, in my experience, the most significant variable in IOL calculation is the keratometry, because there's a variance if you have an IOL master and if you have others, a Pentacam. The K readings are not exactly the same because the machines measure differently or the diameter of measurement is the same. Now, if you have one device, just IOL master or Lenstar, and then you do 3 measurements, sometimes they're also not the same. And then there are natural irregularities such as coma or irregular astigmatism and prior surgeries. So the solutions are, number 1, multiple measurements. Number 2, corneal topography. And then there's this new concept now of total corneal power. There are devices that can measure total corneal power, like the Zeiss, but the Zeiss you need to upgrade, to pay for an upgrade to get the total corneal power measuring device in the iMaster 700. And there are some formulas that compensate or allow you to input the total corneal power. But again, these are concepts that you have to gain experience in. So next, Paul, Sebastian.
Yes, Bobby. I'm going to send. Yes, one question. What is your favorite formula to use for non-toric lenses, multifocal lenses with a normal eye, for sure?
So in your daily practice, a normal patient, no Lasik before, no high astigmatism, what is your favorite go-to IOL formula?
Okay, so the first is Barrett. 61% of the audience are using Barrett. The favorite is Barrett.
Mm-hmm.
And then we have the third generation formula. And there is, depending on the eye condition too.
Yes. Okay. So most of us use the Barrett, and I've been using the Barrett for about four years, and I love it. And the first thing about the Barrett is it's easy. You go to the website APACRS or Barrett, and then it's free, and then you can use it. No? It's easy to teach the fellows how to use it too. So critical success factors for IOL calculation: the source data, the formula, and the A constant. So again, the source. My suggestion is you stick with one kind of biometer and one kind of keratometer that you always use. I don't suggest immersion unless you have to, or very thick lens, but stick to one reliable optic biometer. Probably most clinics will have only one. These the different formulas have their own requirements, but most of the time you will need eggshell length, which is good with the optical biometers, keratometry, and anterior chamber depth. And these are the formulas in the literature. And as you can see, the Barrett, the Hill, they're all very, very accurate now. So use more modern formulas, take time to compute. It's, I think, part of our work as the surgeon is to make sure that the calculation, you put some effort in the calculation, because all the hard work is gone if you order a wrong IOL power. So what is my protocol? I obtain 3 IOL 700 measurements. If there's dry eye, I address it first. And then I counter check the K reading. I counter check if they're post-refractive. And I counter check if there's the cylinder magnitude and the axis. As I said, if they're against the rule or oblique, even 0.6 or 0.8 diopter of cylinder, I will put a toric. So I have 3 different measurements of IOLmaster, and each one we will do a Barrett. So now we have 3 Barrett printouts per eye, and then 2 out of 3 in the emmetrope. I target emmetrope. Some of us target first plus. Now, my suggestion is emmetropia or first plus in the trifocals, and in the EDOFs, the first minus. So 2 out of 3 tells me the IOL power, and that's what I order. How about A constant? So begin with the manufacturer's suggested. Each manufacturer, when you try it the first time, they'll say, why don't you try this A constant? And then you use it 5 to 10 times. And then you see the refractive outcome. But as you're doing these 5 to 10 cases, do not change surgical technique, because if you change, you add another variable. For me, I do not do incisions based on the steep axis. I always do my corneal incisions in the same axis. So I don't change any surgical technique. These are my personalized A constants for all the lenses that I use. So the hydrophilics, 119.0, and the hydrophobic visual, 119.4. The Alcon, the J&J are 119.3. The BNL, Invista and Visatorix, 119.0, and the Zeiss is 119.7. So these are my own personalized A constant. You can be a little bit low or high depending on your experience with the lenses. So intraoperatively, if it's toric, I mark slit lamp and intraop. My capsulotomy is as close to 5 millimeters as possible. Always same area corneal incision. Remove viscoelastic behind the IOL, and I always tap the IOL down. So I want the lens to be deep in the bag, and I always leave the eyeball firm. Post-op, I always use non-steroidal, whether they have an ERM or whatever, diabetic, non-diabetic, I always prescribe NSAID. And then I do a refraction and vision check 1 week. I trace toric check at 1 week. And I also start them on artificial tears at 1 week post-op. So, Paul, Sebastian?
Yes, Bobby. One question: what is the most common solution for you to use for an unhappy patient? Okay. So the first 42% is eyeglasses, and the second option at 39% is dry eyes treatments. After we have laser touch-up, asking for 6 months follow-up. Only 6% is explant the lens. 7% hardened lens could be a solution, and also 2%.
So as I said, I already start lubricants 1 week if they don't blame yet. Paper, antibiotic, and steroid, they're on some kind of a lubricant just to anticipate some dryness. Of course, in the top part, eyeglasses and laser touch-up, it's more or less because the most common complaint is actually residual refractive error. So in an unhappy patient, I usually have 4 points, four tasks. Number 1, I talk to the patient. So all of us need to first, I think we need to empathize with our patient, acknowledge that they're not happy. So it doesn't get us anywhere if we argue with the patient. But our measurement is 20/20. Why are you not happy? It's probably some patients might find that a little bit offensive. So you tell them, okay, I understand that you're not happy. Why don't we do some dry eye treatment? Why do we wait? And of course, if you've managed the expectation of your patient, they're more open to, oh, why don't we try some glasses if you'll see better? So find the cause, because sometimes you have CME after surgery. That's why I always start in the immediate post-op NSAID. So the usual is either high IOP or some CME. You formulate a solution, meaning if you need to rotate the toric, you need to decide in less than a month so that it's easy to rotate. So you formulate a solution and you tell the patient, I actually tell the patient there's an action plan. Step 1, we will try this. After 1 to 2 weeks, we will try this. And after 1 to 2 weeks, we will try this. So the patient feels that you have a plan. If the patient sees that you don't know what's happening, then the more they'll panic. So I think that it's important for us to tell the patient that we know that they're not happy, and we are trying to find the cause why they're not happy, and we have a solution or at least a compromise, and that they will not go blind even if they're not happy. So I think these are important to convey to the patient. So the most common for me is an off-target outcome. I confirm with the trial lens. If as astigmatism, I do this eye trace toric check to find out if I need to rotate or not. Or you can do the astigmatismfix.com website and you can check there. And the most common unhappiness is residual refractive error. So I always tell them they might need glasses, so try glasses. And if they still insist on spectacle independence, then consider Lasik. But I usually do it 3 to 6 months after. So thank you, and we're here to answer any questions from the audience.
Yes, Bobby, we are quite over time, but it doesn't matter. We are going to take at least 10 minutes to answer the question here. So I'm going to choose the first one. It's a more comment. Interesting concept on chromatic aberration. I thought that chromatic aberration was dependent on AB number of the material. Okay.
Yeah, the AB number is a factor, and it's also measured, and it also changes by the design of the lens. So it will affect AB number, wavelength, and all that. So all of that will be affected by all of that will affect the chromatic aberration. Yes.
Second question, what are the ridge? So I think it's the ridge tech, so the wave on the phobic optics and not on the philic optic lenses.
Yes, the ridge is on the haptic. It's not the toric marks. The toric marks are still in the optic, but the ridges, they're smooth, but you can see them. It just differentiates the hydrophobic from hydrophilic, because or else you cannot tell the difference. But it has no optical effect.
Bobby, can I make a comment?
Yes, yes.
Just the wave on the optic on the phobic lens is to avoid also to have stocky optic on the optic during injection, because we know that the raw material, the hydrophobic raw material, is very sticky. So it's just to avoid to have sticky optic on the optic when you are going to inject the lens in the capsular bag. As we know, we know this issue with Acrisoft raw material.
Mm-hmm.
Have you any experience on post-op difference between Symphony and Finevision Triumph?
So I've done a lot of Symphony IOLs too, and we don't have a comparative study. If you're asking, we have not done a comparative study. Probably somebody will do a comparative study when the Triumph is out in the market. But from my experience with putting Triumph and putting Symphony, the far vision is as good in the Triumph and the Symphony. The intermediate vision is as good. It's the near vision that is better with the Triumph than the Symphony because of the trifocality. The Symphony is not a trifocal, so that's why they don't have enough near vision. So that's the main difference.
A question from Vinod Goba. You know Vinod Goba? Thank Bobby. Any positive experience with mix and match, Triumph and Finevision? I'm still reluctant after the lack of great success with mix and match with previous presbyopic IOL combination.
Actually, I think that's what's going to happen is when the Triumph is commercially available in all territories, the doctors can now choose if they want to do mix and match, meaning the dominant eye or the far vision eye will have the Triumph, but it has this better contrast and stronger far intermediate. And if the near vision is not enough, then you will put the glistening free hydrophobic or hydrophilic fine vision in the non-dominant eye for near. So it's more or less offers you a troubleshooting mechanism. You know, you also don't know if you put the trifocal first, what if they're not happy with the distance? What are you going to do next, right? They're happy with near, they're okay with intermediate, they're not happy with the distance. What are you going to do? It's either you're going to put a monofocal, you're going to put an EDOF on the brand, or you're going to put a Triumph. But you're not going to put the same lens because that first lens already doesn't have enough distance, which is what is usually the complaint of all these diffractive trifocal or bifocal lenses. So mix and match is a good strategy to begin with or to talk to the patients about. So usually you can tell the patient like me, oh, there's no way to simulate what your vision is after implanting the lens. The only way to know is after we've implanted the lens. If you're happy, we implant the same lens on the second eye. If you're not happy, then these are the choices. I think part of the conversation before surgery is either a planned same lens or a planned mix and match. But I think that will happen more and more because more doctors have experience even in other brands of mix and match. So it's not so unusual now to have a different lens in each eye.
Okay, thank you, Bobby. Did you ever experiment toric IOL rotation after 3 years? but I don't know which lenses.
No,
Any rotation?
I will usually rotate at the latest at 1 month. So the refraction at 1 day may be not reliable, but at 1 week you already know more or less if there's a high cylinder. Number two is I dilate the eye at 1 week to check if the axis is where I intentionally put it. So you have, for example, the toric calculator tells you put it at 10 degrees. And then at 1 week, it's at 10 degrees, but the cylinder is minus 1.5. Then it's either you still have corneal edema in the wound, or your the architecture has changed because of your wound, so you have to rotate it one way or the other. And I'd rely on the eye trace toric check, or maybe astigmatismfix.com. Wait another week, repeat the refraction, and then recompute this. And then if I need to, I will usually rotate within a month. Because if you rotate because the patient's not happy, even if I have minus 1.5 cylinder, but the patient's happy, I'm not going to touch the eye. So you are forced to do an action because your patient's not happy. And I don't think they'll wait 3 years for you to move. So I think 1 month is enough to make your decision to rotate or not to rotate the lens.
How about targeting minus 0.5 on EDOF on Triumph lenses to improve near vision or EDOF? Is it an option?
Yes, so the EDOF, so for example, when I use the Symphony, I will usually target them first minus 0.25 or minus 0.5 in the first eye. The reason is to augment the near of that eye. And then I will adjust the targeting of the second eye depending on how I get it. But the Symphony is different from the Triumph because the Triumph is more diffractive and it also has some near already. So I think 0.5 is too much because you will sacrifice a lot of distance vision. And most of the time, I'm not saying all the time, but most of the time, the patients are unhappiest when their far vision is not enough for them. So I don't like to sacrifice far vision. I would rather prime the patient that they will need reading glasses than far vision glasses. But for the Triumph, maybe my first minus is what you target. Of course, if you get 0.5 with the first minus, it's fine. But if 0.5 on IOL calculation planning means there's a second minus, it's a lot because if you overshoot the minus and end up minus 0.75, you're in trouble, or minus 1. Because you don't know if your pre-op selection is the actual refraction after surgery anyway. If you have a cylinder, then that adds to the spherical equivalent. So you target minus 0.5, you get minus 2.25, but you have minus 1 diopter still. So that's more than 0.5 diopter spherical equivalent. So remember that there's also a cylinder component to the spherical equivalent after. So not too much of a minus in any of the diffractive trifocal IOLs, even the Triumph. First minus is the most.
Okay. For post-LASIK patient and wants to have a good near vision, will you recommend the latest Finevision Triumph to your patient?
Okay, so the tricky part is the post-LASIK because first, you need to check the topography if there's some irregularity there. So if it's an irregular cylinder, or even if there's no refractive cylinder, but the cornea looks irregular, then you kind of need to be careful. But even saying that, I have been putting trifocals on post-LASIK patients. So, but you have to warn the patient that if they're not, usually this is what will happen. You make sure first that you're using Barrett through K or through K toric. Second is, once you implant the patient, if they're happy, you're fine. But if they're not happy, if you put a trifocal, usually they're good at near and they want near, but they don't remember that you told them that if there's good near, there's less far. They will also demand good far vision because these post-LASIK patients have been all their life spectacle free, or they already had that experience and they demand that from you. So managing the patient expectation is very crucial here in the post-refractive. But of course, you can use, and then you tell them that for the second eye, If they're not happy with the far vision, you have to use a monofocal in the second eye or this small aperture IOL in the second eye.
Okay, Bobby,
But
very
again, it's first eye.
practical question. What lens do you recommend for those who are playing golf or playing tennis?
Okay, if they're playing golf or playing tennis, then I always tell them that monofocal or EDOF is the best. Then you're safe that way rather than put a trifocal. But you know, the golfers and the tennis players, they're also demanding in terms of near. So again, it's your conversation with them. And if here's another thing, no, if they were myope before surgery, I'm more careful because they had good near and they have glasses which give them good far vision. So for them, even if they wearing glasses, their point of view is this is good vision far and near. And then versus the hyperope, where the hyperope of a +1, +1.5, they don't wear glasses, but their far wasn't very sharp anyway. So they appreciate the near, and then they're not so demanding with the far because they're, unless they're plano, but if they're +1, +1.5. So for these active patients, again, the same conversation is you tell them that number one is if they're not happy with the first eye in terms of the distance, you have to put a monofocal in the other eye. But it's their choice.
Okay.
But yeah.
If in your biometry that we have done more than 3 times,
Yes,
the lens differs by more than 1 millimeter consistently, which
yes.
one will you follow, assuming the visual acuity and density of cataract is similar?
What I will do is, if I see that, I will put the patient on dry eye treatment for 2 weeks and ask the patient to come back. Because usually, you cannot average these things. No, it's not. It's a too big a risk. I will just tell the patient that your measurements are inconsistent or not consistent, and then I think you have some dryness issues, and then I will treat them with dry eye, a lot of lubricants, and then probably treat meibomian gland dysfunction, do something, and then 2 weeks that they're on lubricants, come back, and then repeat the measurement. And then you will get your answer there after 2 weeks.
Okay.
But don't force yourself. You know, if your gut tells you there's something fishy, there probably is something fishy. So don't push it.
Thank you, it's clear. And do you take in consideration the pupil size of the patient for Finevision implantation?
Okay. So I've been measuring pupil size for the past many years. And the funny thing is most of the old patients have 3 millimeters or less. When you measure them photopic, mesopic, about 3 to 4. So what I'm worried with more is too big pupil size than too small. So in Asia, I think most of our patients don't have big pupils, but I think in Caucasian countries you have. So I will be very cautious if your mesopic pupil size is more than 5 or 6. But the question to ask is, how many of you measure the photopic and mesopic pupil size before surgery? Because not many of us do, but some of the devices have. Like the iTrace has, the iLmaster has. So maybe you want a cutoff of 4. And then if they're above 4, then you are forced to do a pupillometry, photopic and mesopic. And then you cut off is 5.
Okay, thank you, Bobby. I think it was the last question because we have 15 minutes after 3. So I would like to thank you really much for your presentation. And I think it's very clear and precise. You gave us really clear and precise answers, and which I have no doubt will help many of our listeners in their day-to-day practice. I would like to thank Marie and Rebecca for the support to organize this webinar. So I look forward to seeing you on our next webinar on next Monday, 18th at 2 p.m. same time, Brussels time. Dr. Pavel Stodulka from Czech Republic will share the new isofocal technology and its six months already follow-up with the ISOPure 123. So Bobby, I would like to thank you again. You are really a good teacher, to be honest, very good. Thank you very much for your presentation, just very crystal clear. And thank you again, and take care, everybody. Thank you, bye-bye.
Thank you, everybody. Thank you for tuning in. Bye.
Thank you, Bobby.
Thank you.